for the interest of time, we'll get started. So thanks again, everyone, for joining us today. It's our pleasure to welcome you to another NIRx webinar and to host Dr. Karnik Kazazian, who will be talking about some of his research using fNIRS in the ICU. And the title of his talk for today is Uncovering Hidden Consciousness in the ICU, the Role of fNIRS in Brain Injury Care. It's my pleasure to host and moderate this webinar with our wonderful event coordinator, Kemi. So if this is your first time joining one of our webinars, welcome. And just to tell you a little bit about our company, so for the last 20 years or so, NIRx has been manufacturing and developing state-of-the-art NIRS systems. And our goal is to really support our users and provide the best technical and scientific support we can. This webinar is just one of our efforts to showcase some of the exciting research that's happening in the field. You're welcome to connect with us on our various social media platforms, as well as I encourage you to subscribe to our newsletter, where you'll hear about the latest product features and releases, as well as some of the featured users' research. We promise not to bombard you with a lot of emails. We'll just reach out a few times a year. So a few housekeeping points before we get started. Everyone on this call will be muted. Questions are welcome at any time. Please use the Zoom chat function, and we'll take the questions at the end of the presentation. The content will be made available on our website in the upcoming days. And if you have any further questions or interest in learning more about our products, you're welcome to reach out to us at consulting@nirx.net or support@nirx.net. So without further ado, it's my pleasure today to introduce Dr. Karnik Kazazian. So Dr. Kazazian earned his PhD at Western University under the mentorship of Doctors Adrian Owen and Tennille Gofton. His research focuses on leveraging advanced neuroimaging techniques, including fMRI and fNIRS, to enhance the detection of consciousness and predict recovery outcomes in critically ill patients with severe brain injuries. Dr. Kazazian also completed part of his training at Harvard Medical School and Massachusetts General Hospital with Dr. Brian Edlow to better research how neuroimaging can improve the diagnosis and prognosis of brain injured patients. Dr. Kazazian has published his work on fNIRS extensively in very prestigious journals such as the Lancet Neurology and PNAS, and has been invited to deliver talks at numerous international conferences highlighting his contribution to the field. He's also won multiple federal awards, including 4 of the Canadian Institutes of Health Research Awards, such as the Banting Postdoctoral Fellowship and the Banting and Best Doctoral Awards. And with that, I would like to hand over the virtual mic to Karnik, and looking forward to your presentation.
Wonderful. Thank you so much, Andrew, and thank you so much to NIRx for inviting me to give this talk. I'm just going to take a second to share my screen. And how are things looking from your end? They're good? All right. Yeah, so I'm super excited today to talk about some of the work we've been doing here in London, Canada, about leveraging fNIRS to, help us understand the comatose brain in the intensive care unit, and 2, to see if we can use fNIRS to detect consciousness in patients that appear unresponsive in the intensive care unit after having a severe brain injury. The objectives of my talk today are, 1, to discuss some of the current limitations we have in the diagnosis of consciousness and the prediction of outcomes for patients with acute brain injury in the ICU, to talk about some of our recent advantages in leveraging fNIRS to better understand brain function in the intensive care unit, and then talk about some of the benefits, but also the clinical considerations of using fNIRS in an intensive care unit setting. So just to sort of orient all of us to the same page, an acute severe brain injury is a very severe medical injury, oftentimes from a cardiac arrest, from a traumatic brain injury after a car accident, from a stroke, from a hemorrhage or a hematoma or a bleed in the brain that renders a patient unresponsive in the intensive care unit. For various sorts of life-saving care. So many times patients are intubated and completely unresponsive. They're on various types of medications and sedatives to control their brain injury. Oftentimes, surgical interventions are warranted, such as removing parts of the skull to, take care of swelling of the brain. On various sorts of pumps, wires, drains, feeding tubes, and it really requires an interdisciplinary team of medical experts to care for patients who've had a brain injury and are unresponsive in the intensive care unit. So it's a very, very intense and very, very traumatic experience. Oftentimes, within the first few days after a brain injury, if a patient is not waking up or is not showing signs of consciousness, very difficult decisions have to be made. Do you continue with aggressive life-sustaining care in hopes that a patient will regain consciousness and go on and have a recovery that and a quality of life that is acceptable to them? Or do you transition a patient to comfort-focused care and allow them to pass away in the intensive care unit from the withdrawal of life-sustaining measures? And as you can imagine, these decisions and these conversations are really difficult. They're difficult because doctors and medical teams just don't have the answers to them. Other common questions that families or loved ones ask in the ICU is, can my loved one hear me? Are they still in there? Will they ever be the same as they were before their brain injury? And truthfully, with the current tools that are used in ICUs across the world today, we just don't have answers. Now, the leading cause of death in the intensive care unit is not actually from the brain injury itself, but it's actually from the withdrawal of life-sustaining therapy. Now, I just want to give the caveat, this is very specific to Canada, and this is very specific to North America, more specifically to the United States and to Canada. And I'm fully aware that across the world, practices in the withdrawal of life-sustaining therapy and whether or not this occurs is extremely variable. So just keep that in mind. But I do want to highlight that 70% of the deaths after brain injury occur from withdrawing life-sustaining therapy. 50% of these deaths occur within the first 72 hours of ICU stay. And what we know is that there's a lot of variability in criteria for withdrawing life-sustaining care. And I think this is really elegantly highlighted in a study that's come out of Canada, where essentially a mock clinical case was sent to hundreds and hundreds of intensivists and neurologists. And they asked neurologists and intensivists if they thought this patient would have an unfavorable outcome 1 year post-injury. And what we found, or what they found, I should say, is that 1/3 of physicians agreed that the patient would have a good outcome. About another third, or just over another third, um, thought that the patient would have a poor outcome, and then about a third thought the patient would have a neutral or an unknown outcome. And so this shows that there's a lot of variability in how doctors think that a patient is going to do down the road. And a follow-up question to that was, well, are you comfortable withdrawing life-sustaining therapy? Um, Based on this clinical scenario. And over 80% of physicians said that they would be uncomfortable or they just would not have the right tools or knowledge to be able to go forward with that care. And um, and I really want to highlight this because it really just paints the picture that there is no set of criteria, or there really are no tools that can really help us understand when we should continue versus withdraw care. Outcomes after brain injury are also extremely variable, ranging from death all the way to full recovery. And generally, in the brain injury field, we would consider a poor outcome anywhere from death to severe disability with a full-time care. And we would consider a quote unquote good outcome to be someone that has a moderate disability or can make a full recovery after their brain injury. And again, the caveat here is that these definitions of poor and good outcome are extremely variable, and it really does depend on your personal beliefs. But I bring these definitions up because oftentimes in our field, when I say poor outcome, this is what we're referring to, and when I say good outcome, this is what we're referring to over here. Now, part of the problem, or the reason why deciding to continue versus withdrawing life-sustaining care exists is because there are two fundamental issues, which is one, it's actually extremely difficult to predict who's going to wake up after having a brain injury in the intensive care unit. And it's also very difficult to detect signs of preserved consciousness for patients who are in the intensive care unit following a brain injury. With respect to predicting recovery, there are a whole bunch of different tools that can confidently tell us which patients are going to have a poor outcome. So, in other words, we're able to identify the patients that have virtually no chance of making a recovery after brain injury. However, the flip side is not the same. There are no tools that can predict which patients will have a good recovery from brain injury. In addition to that, it's actually very hard to detect signs of consciousness in patients who are in the intensive care unit for a number of reasons. And now, when I say detecting signs of consciousness, what I mean by is being able to look for signs of command following. So, asking a patient to give a thumbs up, to wiggle their toes, or lower level signs of consciousness, like being able to perform eye tracking or being able to localize to painful stimuli. So, that's when you essentially apply a very uncomfortable stimuli to a patient and they try intentionally to get rid of that painful stimuli. And traditionally, we capture signs of consciousness using standardized scales like the Glasgow Coma Scale, which is a scale that ranges from 3 to 15 that can quantify how aware someone is. Or we can use more advanced scales like the Coma Recovery Scale that can look for more subtle signs of consciousness. But even with these very advanced behavioral measures, we still miss consciousness in a whole subset of patients. And so, over the last 20 to 25 years or so, various advanced neuroimaging techniques have been developed to one, better predict which patients are going to wake up from coma and go on and have a good recovery, and two, to actually detect signs of preserved consciousness in patients that appear to be entirely unresponsive, yet their brain activity is telling us that they're actually in there. A bunch of this work has focused on functional MRI and EEG. So I'm here really to tell you about the more newer advancements and more specifically the fNIRS component of the advanced imaging that we can start to now use in the ICU. And really using fNIRS with brain injury patients, both in the intensive care unit and in patients who are chronically unresponsive. So patients who have been unresponsive for months, if not years, in more community-based settings, really builds up off of almost now 25, 30 years of research. And what this slide is showing you is just some of the key studies that have happened from 1997 all the way up until this year that have been using advanced imaging to detect consciousness and to predict recovery in patients that have had a brain injury. And you'll notice that all of this research is exclusively with functional MRI, EEG, and PET. And so hopefully, when this figure is updated down the road in 10, 15 years from now, we'll have a bunch of fNIRS studies that are building on this really incredible 25 years of research. So let's get into it. Let's talk about how we use fNIRS in the ICU and why we're using fNIRS. So I think this is a crowd where I don't really need to get into uh, the specifics of how fNIRS works and the physics behind it. But what I'll show you here, excuse me, is what our setup looks like in the intensive care unit. So we use a full head montage with the NIRx fNIRS system. We bring our cart to the bedside. We set up our cap on the patient. It takes about 20 to 30 minutes, and it does take a team of us, about 2 to 3 of us. And we work really carefully with doctors, with ICU staff, with nurses, with respiratory therapists, to make sure that we are doing this in a safe, responsible, and in a way that respects the care staff, as well as make sure that we're able to get as much information in a very limited amount of time that we have in the ICU. Um, I do want to, touch on a common question that I often get is why use fNIRS in the ICU when we already have well-established techniques like functional MRI or EEG that that essentially give us information that fNIRS can already provide us. And there's really 6 points that I always like to talk about, which is one, of course, with fNIRS, we're able to get multiple measures of brain activity by measuring both oxygenated and deoxygenated hemoglobin. fNIRS offers us spatial resolution at the bedside that we just cannot get with EEG, which is really important. It also offers us temporal resolution at the bedside that we can't get with functional MRI. Of course, doing testing at the bedside has many less safety risks. We mitigate the need to transport a patient to an MRI suite. And as you can imagine, transporting a critically ill patient who is on mechanical ventilation, who's hooked up to various pumps, wires, and drains, is a very laborsome and very challenging and very risky task. The benefit of bedside imaging allows us to make sure that a patient is comfortable, that they're not removed from the environment that they're in. And of course, bedside imaging has less confound. So we can generally reduce or turn off sedation when we test with fNIRS at the bedside. We're able to control for noise, for light, and all of this gives us a higher quality recording. I want to talk about the different types of paradigms also that we've been using with patients before I actually get into the data, just to sort of orient everyone. Um, and essentially, each paradigm that we use requires a greater level of awareness. So it tells us an extra level of brain processing along a hierarchy. So we use resting state measures to see how the brain is doing at rest in the absence of any external stimuli. We're able to use somatosensory processing tasks where we apply a median nerve stimulation to a patient's hand and see if the parts of the brain that are responsible for perceiving touch remain intact. We use an auditory processing task where we can further look at speech perception and language comprehension. And then we can use a command following task. And this is where we ask a patient to imagine playing a game of tennis or imagine walking through their home. And by completing this task, despite them being unresponsive, we're able to see whether or not they're still conscious. Because in order to be able to complete this task, in order to imagine playing a game of tennis, not only can you have to hear the instructions, but you have to be able to actively act on those instructions as well. And so that is a measure of consciousness. However, most of the fNIRS research, and really this applies to any kind of imaging modality, really focuses on assessing group level activity. And so before we can even see if we can use fNIRS in the ICU, it's really important for us to see how these tasks that have commonly been used to assess for brain function with fMRI and EEG, do they even work with fNIRS? And what is the individual healthy control reliability like? And so, in one of our papers that we published this year, we were really exploring the single subject utility of using fNIRS in healthy individuals before even applying it in the intensive care unit to understand how reliable our single subject measures were. What this shows you here is for resting state networks that we looked at, so sensorimotor, auditory, frontoparietal, and default mode, and these are networks that are commonly used in assessing patients with disorders of consciousness, and we found that we could reliably detect them at the individual subject level with fNIRS. Um, we also looked at are those task-based results that I mentioned a few slides ago. So we can see in our sensory processing task, we have robust sensory activity. In our auditory processing tasks, we see activity exactly where we would expect it over the auditory cortices. In the motor imagery task, we see activity in the premotor cortices, the lateral premotor cortex, and the right operculum and left supramarginal gyres. These are areas that are heavily implicated with motor imagery. And then with spatial navigation, we were able to detect activity in the left occipital-parietal junction. When we looked at individual subject results, so what percentage of healthy participants had activity, we found varying metrics of reliability. So our very basic auditory tasks and sensory motor tasks, we saw fairly high individual subject results. With the language comprehension task, it was much lower. And I think this is because it's really hard to isolate language comprehension even in functional MRI. And so this is a finding that we also get in fMRI that we replicated with fNIRS. With motor imagery versus spatial navigation, we found that motor imagery was the more reliable paradigm compared with our two command following tasks, and we found that it was reliable about 63% of the time. Functional MRI and EEG is about 70% reliability. So we found that fNIRS is almost as adequate as fMRI and EEG in this domain. And working on methods to better detect covert brain command following. I also want to highlight some other work that was not part of that paper, but it's sort of part of our research group where we're trying to compare fMRI and fNIRS to see spatially how comparable the two techniques are, and then also at an individual subject basis. And this is the group level results to a median nerve stimulation task. And what you can see here is that at the group level, we have a very similar activity in response to the sensory task. You have the fMRI results at the top, and then we have the fNIRS results along the bottom over here. And we see there's a generally good spatial similarity between the two modalities. This is an individual subject comparison where we're just we took the first three participants in the task. We have fMRI along the top and we have fNIRS along the bottom. And what you can see here with participant one is that the fMRI and the fNIRS activity in response to a sensory task are quite comparable. Participant two here shows an example where the fMRI activity was more broad compared to fNIRS. And then in participant three, we can see limited and restricted activity, but identical between the two modalities. Excuse me. What you're seeing here is the results of our fNIRS auditory conditions along the top. And on the bottom is an fMRI paper from, I guess, almost 20 years ago now that originally developed this auditory processing task. And what you can see here is that spatially, the ability to detect areas of the brain that are responsible for sound processing, speech processing, and language comprehension are very similar between fMRI and fNIRS. And so these results help us further come to the conclusion that fNIRS is a reliable imaging modality in the tasks that are used to assess brain activity for patients with disorders of consciousness. We see that for some tasks, it's quite reliable. And so this sort of allows us to now take this work into the intensive care unit and see if we can use fNIRS to detect brain activity in unresponsive patients. So I want to start by showing three examples of how we are using fNIRS to detect brain function in the intensive care unit. So along the top here, we see healthy controls, and we've just selected to show here the speech processing and the motor imagery task. The first patient that we tested had no activity in response to the speech processing and the motor imagery task. And this is expected actually for the vast majority of unresponsive comatose patients, is where you wouldn't expect to see activity. In the second patient, we see that they were able, there was automatic brain responses to an auditory paradigm, specifically in the right superior and middle temporal gyri, in the anterior portions of the temporal gyrus. And what this is telling us is that despite the patient being completely unresponsive and showing no signs of language processing, no signs of consciousness, the parts of their brain that are responsible for perceiving auditory stimuli remain intact. And so the signals that are traveling from your ear to your thalamus and to your auditory cortex remain intact, and those cortical structures retain the ability to perceive and process auditory stimuli. And so we're already learning more about this patient than what the standard behavioral clinical tools would tell us. In the third patient, again, another unresponsive patient who is in a coma in the intensive care unit, they have bilateral auditory processing. However, when we asked the patient to imagine playing a game of tennis, we saw consistent and repeated activation. And I just want to point out the right premotor cortex. And I really want to emphasize here that in order to get this result, the patient has to be able to hear the instructions. They have to be able to understand the instructions. They have to be able to remember the instructions, and they have to be able to modulate their brain activity on and off to every single instruction over a course of 5 minutes to imagine playing a game of tennis. So, in other words, you need to have working memory preserved. You need to have executive function preserved. You have to have task inhibition preserved in order to generate this response. And so, this tells us unequivocally that the patient was aware, despite them being entirely unresponsive um, to behavioral examination. And so this is how we would detect consciousness in a comatose patient in the intensive care unit in the ICU by looking for this positive result when asking a patient to imagine playing a game of tennis. And I'll also just emphasize that this paradigm is not novel to fNIRS, but it's a paradigm that's been used now for almost 20 years in patients with disorders of consciousness and in brain injury research. So it's an extremely well validated across the world with multiple different imaging modalities. And what I want to show you here is actually the first 27 patients that we tested um, with the command following task. So what we see here is healthy controls along the top for reference, and we have patients with varying brain etiology, stroke, cardiac arrest, various types of encephalopathies. Um, Tested on various days of ICU stay, ranging from day 2 to day 24, all unresponsive and showing no signs of consciousness. Yet, 6 of the 27 patients were able to imagine playing a game of tennis. So that's almost 20% of patients who are in the intensive care unit that appear to be unresponsive are entirely aware, and this has very big implications if we think about what I was talking about at the start of this talk, with respect to continuing life-sustaining care versus withdrawing life-sustaining care. If 1 in 5 patients in the ICU are aware, and 70% of deaths are occurring from the withdrawal of life-sustaining therapies because physicians and medical teams don't have the proper tools to decide and understand if a patient is aware and also the capacity for a long-term recovery, then this has major clinical implications. And many clinical and regulatory bodies are now starting to understand these implications. And in fact, using advanced imaging techniques are now starting to become endorsed and recommended to be implemented in ICU settings in order to make sure that we're able to identify patients who are conscious yet are appearing to be behaviorally unresponsive in the intensive care unit. And the other exciting thing we can do, I know what some of the final points I want to make, because I think we're close to the end of the seminar, is that we can take this one step further, and I want to highlight some of the work that Andrew did during his PhD. Specifically using fNIRS as a BCI in the intensive care unit. So once you can establish that someone is aware with advanced imaging, you can then start to leverage this ability to covertly command follow to ask them very clinically relevant questions, such as are you in pain? Do you feel safe? Do you are and then also ask them questions, baseline questions about correct last name. So in this example here, Andrew and their team first wanted to establish if the patient was not only aware, but also if they were oriented. And so they correctly answered their last name in addition to several other questions. And so once you can ask low stakes questions and prove that someone is oriented, then you can ask more medically relevant and necessary questions like, do you feel safe? And in this case, the answer was a yes, because you can see that change in oxygenated hemoglobin. And then, are you in pain? And here there was the answer was no. And the final couple points I want to make is uh, It's really easy, I guess, to come and say, we should be using these tools and it's important to be using these tools, but it's also think it's really important to emphasize um, how we should use these tools, which patients would benefit from using these tools, how these tools can be implemented in a clinical setting, and really translating the science to clinical practice. And this is something that I personally feel pretty passionate about, and the team that I'm working with. And so we're starting to develop flowcharts and clinical guidelines that doctors, scientific teams, clinical staff can follow these algorithms. And I won't go through the algorithm in detail, but generally the takeaway here is that we're trying to make more objective, standardized criteria to make it clear when these tools would be beneficial on an individual subject basis. And here's just an example of that. I do want to highlight some of the practical considerations of fNIRS in the ICU, and these are more reflective of working in an ICU setting rather than fNIRS in particular. But when we use our full head coverage, and for us it is important to use a full head coverage because we use various types of tasks that require us to monitor various areas of the brain. It does take a long time to set up, and now when I say long time, I'm saying 30 to 40 minutes, but that's a very long time in the intensive care unit, in addition to 40 minutes of testing, because a lot can happen in 10, 15, 20 minutes. The general rule of thumb is that 15 minutes in the ICU can feel like hours because a lot changes in that time and the stability of a patient can very rapidly fluctuate. Um, Patients, when they're lying down, it's hard to sometimes, co-register to anatomical landmarks. And we've been actively working on these techniques, and we have several safeguards in place to make sure that we're doing this. Um, we know, and I think this is something that everyone here can attest to, is that pre-processing methods are very much debated and are very much varied depending on research groups. And this is more so a consideration that we have to keep in mind when we're translating these techniques from science to clinical practice, is that we as a community need to do a better job of coming up with standardized pre-processing methods. It can be hard to use fNIRS with very severe TBI patients that generally have parts of their skull missing, that are all bandaged up, that have drains and stents that are implanted into their brains and that are externally getting rid of fluid and swelling. And so, even with a limited montage, it can be hard to sometimes test with those specific types of patients. Um, and this is more so reflective of our montage, but sometimes we don't get complete coverage over the supplementary motor area. So the strip that kind of goes right over the top of your head, that's crucial for motor imagery. And so these are all things that we are mindful of and we're considering. And I guess just to wrap this up, some of the key things that we've really worked on is showing that we can have adequate sensitivity with healthy controls on an individual subject basis with fNIRS, that it is in fact feasible and practical to use fNIRS with patients who have an acute disorder of consciousness, so otherwise known as an acute coma in the intensive care unit. We are doing our best to make our code and our analyzing processes publicly available. So others who are interested in using this our work and want to implement this work into their settings are able to do so. But also really highlighting that there's still a long way to go from translating fNIRS from uh, highly specialized personnel at resource-rich academic centers who have the means, the financial resources, and the support to be able to do this, to community hospitals, to hospitals that don't have as much funding. And so I think this is an area that's really gonna take off in the next 5 to 10 years. Um, and so with that, I want to thank the wonderful people that I get to work with or on a daily basis, and the people that really have made this possible. I really want to highlight Andrew and Sergio, the who are postdocs at the time when a lot of this research was being completed, and all of the work that you've seen here is really thanks to them and the collaborative effort that we put in. And again, thank you to NIRx for your invitation and the time for letting me share this research, and thank you all for being here. And that's it.
This is wonderful. Thank you so much, Karnik, for the great talk. The floor is now open for questions. If anybody has any questions, please feel free to put it in the chat, or if you prefer to raise your hand and then just unmute yourself, you can ask your question verbally as well. I'll get us started in the meantime with some of the questions that we got during the registration process. So we've got a couple of questions that kind of all hint at the same, theme or same question of prognostication.
Mhm,
So this is a nice question where we say, can we predict the chances of a person coming back to life while being in a state of coma through fNIRS?
mhm. That's a really good question. So, um, there's work with functional MRI and EEG that very convincingly and reliably shows that measuring brain activity with these advanced methods can pretty accurately predict who is going to make a recovery. With respect to fNIRS, we're not there yet because we need to collect data on more patients. And so that's a research question that we're actively trying to answer right now, is to see which of these markers can predict recovery in patients who are unresponsive in the ICU. But I will say that patients who show signs of consciousness, so patients who are able to do that motor imagery task, imagine playing tennis, we know that those patients are much more likely to have a better recovery. They're much more likely to show signs of behavioral consciousness much quicker than patients who are not able to covertly command follow. And the time it takes for them to recover is much quicker than patients who cannot covertly command follow. This is EEG data, but my hypothesis and my guess is that we will have similar findings in fNIRS once we collect data from enough people. So thanks for that question.
Perfect, thank you. We have a question in the chat. What is the emotional experience for you as a researcher while researching on people in coma?
Wow, that's a really good question. I don't think I've been asked that question before. Um, it's really it it's very interesting because um a lot of the patients that we test on unfortunately do not survive. They pass away from their injury, they pass away from the withdrawal of life-sustaining therapy. And so being in a setting where you are, on a daily basis seeing patients and you don't know if sort of it's their last day to if it's the last day that, they will be alive, or if a decision is going to be made to transition them to comfort focused care. It is something that is sometimes hard to grapple with. Um, Also, having family members around while some of this testing is happening is a really an eye-opening and humbling experience. Generally speaking, families are really keen to have their loved ones participate in this type of research, and so as a researcher, that is that's really great for us to see, because a lot of this research depends on families saying yes in probably some of the worst days of their lives. Being able to agree to this type of research is really is something that I'm really beneficial to see on it, or really fortunate to see on a daily basis. And so that's sort of the positive emotional things that can come out of this as well.
Thanks, Karnik. We have another question in the chat from Anna. Hello, I was wondering if you think that other sensory tasks to detect consciousness, for instance, olfactory tasks, do you think that would be something worth implementing?
Yeah, I think this is a really good question. And I think, the point I'm about to make applies to really any sensory task. So, um, I think what Anna's asking, and please correct me if I'm wrong, is that generally, if you apply a sensory task, whether that's auditory, whether that's olfaction, whether that's pain, we know what a healthy person's brain is going to look like in response to that task, a healthy, conscious brain. When we see a patient have similar brain activity to a sensory task that resembles a healthy person's brain, It's not a direct measure of consciousness. It tells us that their brain, or the parts of their brain that are responsible for interpreting sensory stimuli, remain intact. It tells us that, the pathways and the neural infrastructure that is responsible for conveying those signals remain intact. But it's hard for us to definitively say someone is conscious based on whether they're olfaction or their auditory or their sensory stimuli matches that of a healthy person, because it's not a direct measure of consciousness. And so that's why we default back onto tasks like command following, like imagine playing tennis, because you have to be aware to have that positive result. But I think having as many tools as possible in the toolkit for detecting brain activity is crucial, and olfaction is another really great promising technique.
Awesome, thank you. Um, any other questions? Okay. Looks like we don't have any more questions, and we're almost at time. So thank you so much, Barney, for your time, and thank you everyone for joining us today. And yeah, looking forward to seeing everyone in the future webinar.
Thank you, everyone.